I do want to thank Brookings. I want to thank Alice and Dick, Caitlin, Madeline, everybody else here who's been really wonderful, and Bob Bullock at our institute in putting this together. The Rockefeller Institute does have a long history. Many thanks to Dick Nathan for putting together these field networks, which we've done in Medicaid, we've done it in welfare reform, workforce development, and many other areas as well. And we've often had some very good researchers in our research teams across the country when we have these multi-state systems. But this team is particularly great. We have some very distinguished folks, and they're all quite diverse too, and that's one of the nice things about it as well. This is a kind of inductive research approach, and it's nice to have people with different backgrounds, different disciplines, to be able to have develop insights, different types of insights in understanding and observing how these national initiatives are implemented on the ground. This team in particular, and especially the 5 people here, do have a lot of differences. We've got differences in disciplines. We have 2 economists, we have a political scientist, a lawyer, and a public health specialist. And their careers have been different as well. 3 of them are traditional academics, so not too traditional. They've also been very applied, very active people. 1 nonprofit research advocacy organization, and then 1 former top government executive who's now leading a research center at a major university. So all of them bring different sensitivities, different trainings actually to bear in their thinking. What I'm going to do, since you do have your bios of everybody, you've already been listed in terms of their major titles, I will just simply say that we're going to start off with just a few minutes of a summary of their major findings, just a few for each one of them. And then we're going to have a series of questions. I'll ask a few questions, and then at some point I'll let everybody else ask questions as well. And your questions will be brief and to the point when I give you that opportunity. We're going to start off with the blue state of California. We're going to end with the red state of Morrisey in Texas. Michigan will be second, third will be Florida, fourth will be North Carolina. Micah Weinberg is president, Bay Area Council of Economic Institute. For Michigan, we have Marianne Udow-Phillips, executive director, Center for Healthcare Research and Transformation at the University of Michigan. Patricia Bourne will talk about Florida. She is the Payne H. and Charlotte Hodges Mid-Yet Eminent Scholar in Risk Management and Insurance at Florida State University. Patty, since we've already used 15 seconds of your time, you get a little bit less time. North Carolina, we have Mark Hall, who's our Director of Health Law and Policy Program, Fred D. and Elizabeth L. Turnage, Professor of Law, Wake Forest University, and a non-resident Senior Fellow at Brookings. Same with you, Mark. Mm-hmm. And then finally we have Texas and Mike. So, Micah, start off.
All right. Well, I'm intending on winning the Oscar for Best Presenter today. And to do so, I'm going to tell a story about La La Land. Now, in this case, by La La Land, I mean Region 16 of covered California, California's ACA marketplace. That is the western half of Los Angeles. And what I talk about will really reinforce the conclusions that Michael just shared with the entire group, but I'll give you some local flavor. So the western region of Los Angeles actually in and of itself has 5 million people who live in it, so it's as large as many states. A very diverse population, obviously a very urban area. And there is both a lot of provider competition in Los Angeles as well as a lot of insurer competition. On the provider side, in the broader Los Angeles area, there are actually over 80 hospitals There's not as much hospital consolidation in Los Angeles as there is in places like San Francisco and other urban areas. And on the insurer side, there are actually 7 different insurers competing in this area. And they're of many different types. So you've got Kaiser Permanente, which is our sort of closed network integrated delivery system. You have some conventional insurers putting together PPOs and HMOs, our sort of Anthem plan, our Blue Shield plan. You have Oscar, the plan, sort of new wave. We're going to use a lot of telehealth and be run by Jared Kushner's brother plan. Hasn't done very well. But I'm sure we'll get a tweet to get more enrollment in Oscar here pretty soon, because that's a totally legitimate thing to do. Then you have, very interesting, a couple of Medicaid managed care plans. And so the state active purchasing exchange did a lot of different things. Active purchasing isn't just negotiating with insurers for prices. It's really thinking about, do these marketplaces work? Do they have enough competition? And is there something we can do to bring more competition into the marketplaces? The funny thing about California is, so it's a bunch of people that would prefer to be implementing a single payer system that actually did the best job at implementing a market-based reform, right? They said, all right, well, I guess we like this now. And really thought about, if we're going to have competition, we need to have competitors. No competitors, no competition. HSAs don't make competition where there's one hospital in your town. So a lot of competition in Los Angeles. And one of the really interesting things is, so you hear these, these big headlines, insurers raising premiums 45%. Of course, almost everybody doesn't pay that because they're subsidized. But in Los Angeles, a big issue was that last year, Molina is an insurer that lowered its premium, actually in absolute terms. Molina is primarily a Medicaid managed care plan, competing in the individual marketplace in California, and actually lowered their premium. Now, the issue with lowering your premium is that means that all of your competitors, who are raising their premiums, and the people who are purchasing through your competitors actually see a real substantial premium increase. And we've seen that consumers increasingly are shopping on price. In the first couple of years in California, they didn't do it because they didn't know what was going on, and let's just default to the brands we'd heard of. But in the last couple of years, they've really started shopping on price. So they'll buy Molina, they'll buy LA Care. They don't need to buy, Blue Shield of California just because that's a name that they're familiar with. And they seem fairly pleased with these networks. That's something that folks are finding, which is that ultimately most healthcare doesn't work and you die, right? So no matter what facility you choose, right, ultimately you're going to be disappointed with this consumer product because you'll be dead, right? So they choose Molina or they choose LA Care, and they seem fairly happy with this product, and it's substantially lower priced. So this is creating a tremendous amount of pressure on the higher cost hospitals in Los Angeles. And we are seeing them negotiate absolute rate concessions with the insurers to remain competitive in these networks. So this is actually bending the cost curve. There's a lot more to say, but the thing that just makes me completely want to tear my hair out, I ran into Mark Hall yesterday. He's like, Micah, your beard is a lot more gray than the last time I saw you. It's like, thanks, Mark. But the reason that it's more gray is that I actually see, shocker, you implement a law and it works, right? So one of our conclusions is, if you just don't do this huge part of the law, the Medicaid expansion, maybe it doesn't work that well. Well, surprise, right? If you are an oppositional state and do everything you possibly can to keep a law from working, then you complain that the law isn't working. It just makes no sense. You've got somebody, you want them to run a 100-yard dash, and you cut their legs off at the knees, and then you're like, they're not running quickly enough. This is a failure, right? Well, if you actually focus on making the Affordable Care Act work, then, shocker, it might actually work. And if we repair and replace and do whatever, but then all the blue states decide, we're not actually going to do this, we're going to fight it in the courts, it's not going to work there either. You actually need to choose a system and implement that system And when you do it in a place like California, it can work. But the important thing that I'll just conclude on is, again, local markets, local competition. So you can't put together competing networks in an area with only one hospital system, right? So if we really care about competition, we need to care about competitors. And the competitors we care the most about are actually not the insurance plans, but rather the providers. So, you've got somebody like David Brooks, who should know better, writing a column about can you shop in healthcare and talking about do HSAs work or don't they work. That's beside the point. You can't shop in healthcare if you have no choices to shop among, right? That's what we should care about if we care about shopping and markets and all the rest of these things. And that's something that's totally non-ideological. That's going to be important for the Better Way. It'll be important for the ACA. It's important for whatever kind of policy framework you put in place. And Los Angeles shows it. So that's my comments.
I just have to say, you can tell who's not the academic in this group.
Academic by training, but I thought I'd have some fun.
Marianne.
You can tell who's from California in this group, because I'm not the academic, but I'm not competing for the Oscar because I am from the heartland, right? I'm from the purple state of Michigan. You may not blame us for where we are today, but you may have had a contribution. So I want to add something to, I thought Mike's summary was fantastic. And actually, I thought, Micah, what you said, I totally agree with. But I want to add something to the perspective that Mike gave you, because I think it's really fundamental to understand, in part, why it's unfortunate we are in the change discussion that we're in right now, because healthcare markets, health insurance markets, take time. And to build something takes a tremendous amount of time. And where we are today in the Affordable Care Act is very much built on the history of where I think all of our states have come from. And to see what's happening now, you have to understand that history. So I want to go back a little bit in history for you to understand a little bit about Michigan. In many ways, I would say Michigan is kind of the model of what the Affordable Care Act intended the health insurance marketplace to look like, right? We are a state that even though we have a Republican governor and an all-Republican legislature, we are a state that actually approached implementation of the Affordable Care Act tremendously pragmatically. We were not a state, as you'll hear from some of the others, that was oppositional. We're a state that really wanted to make it work. Our governor, Governor Snyder, is a businessman by background. His focus was on the economics of it. He got the economics of it. In fact, he said, after the law was passed, even amidst all of the rhetoric early on about how terrible the law was, he said if it had been up to him, he would have created an exchange independent of the federal law, because he understood that it would make health insurance easier for consumers, and he wanted to make the market work better for consumers. So he and his administration always approached the health insurance exchange market from that standpoint. In a similar way, they approached the Medicaid expansion from that standpoint. It was controversial with the legislature, passed by only one vote, and actually that was a vote that switched from a no vote to a yes vote after 3 hours of horse trading. But we did get the Medicaid expansion, which was implemented in April of 2014, so there was a little bit of a gap, but mostly early on. We were certainly one of the first Republican states to go for the Medicaid expansion, and again, it was a very pragmatic decision based upon the economics. There was a coalition built across the state that included all the business leaders, all the providers, all the consumer advocates. It was all the health plans. I mean, there was just widespread support because of the economics. So it's a state that got the Affordable Care Act. And as a result, we have actually a fair amount of competition even today with the Affordable Care Act. We have 10 insurers. In 2014, when the act passed, we had 13 issuers in the state. So yes, we lost a couple. We lost the co-op. None of us ever thought the co-op was ever going to succeed to begin with. We lost a couple of the national insurers from the exchange, but they were very small in the marketplace to begin with. They were sort of irrelevant to the market. And frankly, Aetna, United, they don't really know how to work with the individual market, right? We never really expected that they would be successful. So we continue to have a robust market. We now have, I think we started with something like 70 different plan options among the 13 insurers. Today we have 167 plan options. So it's a robust market. Yes, not everywhere in the state. The Upper Peninsula of Michigan, which some people think is better aligned with Wisconsin, but they are part of Michigan today, a trade for Toledo. They have two issuers, actually both Blues, Blue Care Network, which is the HMO, and Blue Cross and Blue Shield of Michigan, the PPO. So there's not tremendous competition, and as a result, indeed, premiums are higher. That's how the market works, right? But they still have choices of plans, and we just completed at our center some consumer surveys. We've actually been surveying consumers since 2009, and actually consumer satisfaction on the individual market is higher than it's ever been with the plan choices they have. And I think there's been sort of some collective memory loss about how bad markets were before the Affordable Care Act for people in the individual market. So 2 words about the history of Michigan so you can understand why we're in the place we are today, and then I'll turn it over to my colleagues. So Michigan has always been a state that has provided coverage on a guaranteed issue basis for the individual market. And actually, if you want to know what will happen with a requirement for pre-existing conditions to be covered with guaranteed issue without a mandate, look at Michigan. Because Blue Cross and Blue Shield of Michigan, since it was formed in 1939, was required to be the insurer of last resort. Had to cover all comers, could not exclude anybody based upon health status. And as a result, they had the sickest population and indeed a failing individual market. The rates were heavily regulated. They were losing millions of dollars and had been lobbying the legislature for years to change their structural status to become a nonprofit mutual insurer, which they achieved in 2014 with the passage of and the implementation of the coverage expansions of the Affordable Care Act. So they dominated the individual market. It was a very old and very sick market. I think the average age in their individual market prior to the Affordable Care Act was 55. And as I said, they were losing millions in that market. They had 72% of the individual market. With the advent of the Affordable Care Act, many new entrants came into the market, predominantly, as Mike said, managed care plans, many of whom had been predominantly serving the Medicaid market. And I think that's the other piece of history that's important to understand in Michigan. Michigan Medicaid converted to a predominantly managed care market in the 1990s. States that has really heavily gone to managed care in Medicaid, and so those plans were ready with the networks that they needed to serve a population like the individual market. I think it's why they've been successful. Many of them are making money in this market. The Blues are not. The Blues have lost market share. Actually, they're happy about that in the individual market. The health plans, the HMOs have gained market. So the Blues, I think, now are something like 60% of the individual market, while the managed care entities have gone up quite a bit. But they're all staying in the market. We can talk a little bit in the questions about what is going to happen in 2018. Very pessimistic about just because of the chaos that is happening in the market right now and some of the utilization trends we're seeing of consumers who are afraid they're going to lose coverage in the market. So I can answer your question now. The rates that were set in 2017, for the 2017 market, Michigan went up 16.7% prior to subsidies. The subsidies, 87% get subsidies in Michigan. Those rates are underpriced now for the utilization we're seeing because of the fear that has been sown in the population. So lots to talk about for 2018, but a little bit of a picture of Michigan.
Thank you very much. Hattie?
Okay. Well, I want to give a little bit of a context on Florida as well. Now moving from states that supported the implementation to an opposition state, and give you first the main takeaway from my research in Florida is that despite the support of the state with the Affordable Care Act and any real active efforts by the regulator in Florida, it's been a real success story over the most of the state. So I want to tell you a little bit about the main points, the things that I think kind of have led to that, have drawn out this kind of success. But I want to give you some of the history of what's going on in the state, a little bit about the market. I'll talk about my main points, and then you can tell I'm a lecturer, right? So I tell you what I'm going to tell you here first. And And then I want to go through some of the concerns that I got from the stakeholders that I interviewed with, that some of which might be kind of common to all of our research here, but some specific things that might have been a concern of the stakeholders I talked to in Florida. So Florida is the third largest state. It has a population over 20 million, and 8% of the population is receiving insurance through the marketplace. That's a pretty big percentage. We opposed the implementation of the Affordable Care Act, also opposed the expansion of Medicaid. By default, the rating areas that were selected for the federally facilitated exchange are the counties. So we have 67 counties. That's the most rating areas in any state. I think South Carolina is next with about 46 rating areas. So I have 67 different markets to try to evaluate, and just in case you're wondering, have they ever thought about trying to combine any of these? The regulator said no. He's really not interested. It's a very passive approach to this. That was the default. They stuck with the default. They never have gone back to revisit whether adjacent rating areas might make a better market. So the state also had, prior to the implementation of the Affordable Care Act, one of the highest uninsured rates in the country. And although the rate is still higher than the national average, it's dropped from about 20% to 15%, at least by 2015. The market, we have about 7 carriers that are participating statewide, but only one carrier that participates on all the exchanges, and that's Blue Cross and Blue Shield of Florida through various different names, Florida Blue, Florida Select, different plans that they're offering. Most of these carriers are also offering coverage in the individual market off the exchange. Blue Cross and Blue Shield, I want to say a few things about them. They have been the dominant carrier in Florida for 70 years, operating in the group market as well as in the individual market. And they also rank highest in consumer satisfaction in studies. So people are really happy with the coverage that they're getting from Blue Cross and Blue Shield. They have reportedly, in my conversations with different representatives from them, they've been very happy with their experience on the exchange, with the ability to form networks. They already had a lot of networks in place. They had relationships with providers all over the state for their individual members. It was very easy to just expand that and say, we'll start offering the exchange plans. So for them, this participating on the exchange was not a really big question, as it was for other insurers that didn't have as much of a presence in the individual market. There are 4 other carriers in Florida that did not have a very big were not real active in the group market or the individual market, but were very active in Medicaid managed care. And those plans have also become key players in the exchanges. So I know this is a point that's come up several times now, is that these plans that have Medicaid experience, and I would add to that plans that had a lot of individual coverage experience in the state, are the ones that have been best suited for the exchange and maybe experiencing the best success there. There have been some major withdrawals in the exchanges. So between the first year and the second year, there was several carriers that joined, and then the next year, some carriers backed out again. Cigna, United Healthcare, and Aetna have all withdrawn from the exchanges across the state. But and Blue Cross and Blue Shield, I mentioned, is the only plan that's actually, or the only carrier that's operating everywhere statewide. So let me get to my major points, and I've kind of touched on at least one of these. Blue Cross and Blue Shield had a strategic advantage in negotiating with providers. I think that points to some success there in Florida that may not see in other places. Another major point, maybe this comes across from specific conversations I had with navigators, is the importance of the navigator network. There was a lot of money put into through grants to the University of South Florida, where there is a particular person there, Jody Ray, who is a shining star there with implementing the exchanges, getting people enrolled. She has formed alliances across the state in rural areas, in urban areas, and some of these, the Florida Chain, Family Healthcare Foundation, the Epilepsy Foundation. She's made alliances with all of them to reach out to people, and I think that that's probably one of the key reasons why we've had so many people sign up for the exchanges in Florida. My other major point, I guess I already touched on too, had to do with the Medicaid providers. Major concerns of the stakeholders, so let me just come back around to some of these. The navigators are not that concerned about what's happened with competition. They said there are plans available for people everywhere. Even in the rural counties like Gadsden County, which was one that I focused on, there are 13 plans. They're all being offered by one carrier, but the navigators said people are satisfied with being able to choose one of those. The prices are high, but the navigators did not express a lot of concern about that. The regulator also was not that concerned about the number of carriers that are in the market, is not doing anything actively to try to encourage them. He's had conversations. Most of the carriers say, we just can't make money, and he says, okay, I understand. So that's been maybe a problem, and maybe a problem going forward. However, the regulator and some of the stakeholders argued that they did not think that, even though they see a potential for a death spiral with prices rising and more carriers dropping out, that it will level up. That most of them, and the regulator especially, said that he thought that this next year we would start to see with the premiums leveling out and the utilization as well leveling out. I think I'm running out of time, so I'll move on because I think I touched on most of the main concerns that I had to address. Okay. Thank you.
All right. Yep. Thank you.
Yeah, and so when I made that crack about who's the academics, I didn't mean anything about substance or style. I meant that all the academics have notes in their lap, and so to read my notes, I'm going to put on my glasses here. So North Carolina is similar to Florida in many ways. It's only about half the size, but many of the features are the same, including oppositional state, no Medicaid expansion, high uninsured rates previously, but very high take-up, very effective navigator outreach, and so Florida and North Carolina are often ranked side by side in terms of the largest percentage of eligible population who've enrolled, but also very high prices. And so to paraphrase Dickens, I think that North Carolina is sort of the best of markets and the worst of markets, or some combination of both. And so despite having very high prices and sort of puzzlingly slow because the healthcare cost index is not among the highest in the country, but the ACA premium rates are among the highest. Much of that is buffered because almost 90% of the enrollees are subsidy eligible, and almost 2/3 of those are below 250% of poverty, so receive substantial subsidies. So the effective price remains quite affordable. So some of those themes that you just heard from Patty, I heard as well. But I want to focus a bit more in terms of market structure and entrance and exits, because, and particularly the kind of networks that form, to kind of add to the dialogue a bit more. So similar to Florida, Blue Cross is the only statewide carrier. Prior to the reform, they had 90% of the 85% of the individual market, and the other carriers had less than 5%. So there was effectively no significant competition. Previously, people would say, well, Blue Cross owned the market and dominates and what have you. Post-ACA, Blue Cross's share dropped from 85 to 65. Still, the largest, but Aetna and United each rose up into the middle to high teens in terms of market share, similar market shares to become quite significant. And so Aetna was there from the beginning, mainly in the 1/4 of the state that composes half the population, the major population centers, Charlotte, Raleigh, where I'm from, Greensboro, Winston-Salem. And then Aetna, which had nationally stayed on the sidelines the first year, entered the second year. And interestingly, they each entered with quite distinctive market network structures. So Aetna's strategy was to partner with named healthcare systems, this co-branding that Mike referred to. So initially with Duke in the Raleigh area, And then with one of the premier systems in the Charlotte area, Carolinas Medical Center, that also covers part of South Carolina. And it was sold as the Coventry was the corporate entity that subsequently was acquired by Aetna, but it was sold as the Duke Coventry / I forget the trade name. And then when United entered, they came out with a gatekeeping HMO. They sort of went back to old style 1990s plan structure, in part as a way of creating a network, because contractually they were able to do that. Focusing on the physician contracts by just selecting a certain group of primary care physicians they thought would be good gatekeepers, and then putting in referral requirements for specialists, and didn't have to go out and renegotiate networks with hospitals that way. And so that was an interesting move. And so you had these sort of standard PPOs the Blue Cross offered side by side with really sort of an accountable care organization structure, because the Coventry / Aetna idea was to really embrace the new thinking of population health management and value-based payments and such. And I heard stories of really using the ACA as an opportunity to create this new type of ACO-based type of product with a critical mass where you could put it out there and sort of, if you price it right, be pretty confident in getting 20, 30,000 lives, which is enough to kind of get the thing up and running, and then start to sell it to small groups and eventually large groups. So really, sort of a health policy, dream come true. I mean, I almost called up Alan Enthoven and said, "Hey, managed competition's working, just the way competing brand health systems being driven by, sort of defined contribution, consumer level shopping." And it all sort of fell apart. So Aetna pulled out nationwide for corporate reasons that we've read about. United pulled out nationwide first, and then Aetna pulled out nationwide. And of course, there's controversy about Aetna's reasoning. Many people feeling that it had to do with the merger review by the Department of Justice. But in any event, I heard sort of puzzlement about why Aetna didn't selectively remain in some markets, including North Carolina. But as Mike said, they still are on the sidelines, suggesting this potential of reentry. And some of these networks that had been formed still exist in the group market. And so you kind of have this positive spillover. Economists use negative words to convey positive ideas, like spillover sounds bad, but it's actually good. And so when something good happens in one market and it spills over to the other, you see that happening with some of these networks. And the other important kind of spillover thing that happened was that Blue Cross responded to these new network structures by creating its own limited networks. It created two forms of limited networks. One was straightforward price discounting, and the other was more in this ACO type of model, partnering with designated health centers. That said, all this vibrant competition was happening primarily in the urban areas. As Mike said, that you don't see this happening in the rural areas where there's only one system or one group of specialists to deal with. And even in the urban areas, it wasn't consistently true. It was more so true in the Raleigh area and secondarily in Charlotte, and less so in some of the other areas. But so those themes are all resonate with what Mike said. But as far as distinctive points, I think one of the things about competition in North Carolina is that principally, aside from the Blues, the carriers were national carriers. We don't have local regional carriers. These health systems haven't yet formed insurance companies. But that might change. So when decisions were made nationally, they impacted our state market across the board. Prior to that, you saw these national carriers actually expanding their state reach, so they weren't contracting. So United started with about half the states and half the counties and expanded to 3/4. Coventry started with about 1/4 and was expanding to about 1/3, but then the national entities pulled them both out. So there weren't any sort of local regionals to kind of fill that void, but many people I spoke to said that that's inevitable, that this condition of Blue Cross being the sole carrier just won't last as long as the market stabilizes, as long as there's a potential to remain profitable. So again, the big open, $64,000 question. Were the 2 years of steep price increases sufficient to stabilize the market? We'll find out soon enough, I think, or maybe not soon enough, but we'll find out soon. If that's the case, most people felt that there would be new entry into the market. So Aetna is still poised to reenter. Importantly, Medicaid hasn't expanded, but traditional Medicaid in our state has not been managed care, but we've recently embraced Medicaid managed care. We have a waiver proposal in with CMS right now to implement statewide Medicaid managed care, and so there's a lot of activity right now forming new carrier entries or national carriers looking at our state. And the thought is if they enter the state for the Medicaid managed care market, there's a good chance they'll also enter into the exchange market, given the symmetries we've seen elsewhere with that ability. So it's an interesting thing where at the moment there's very little or no competition among carriers, but everybody seems to think that there's this potential competition, that it's poised for more. In fact, the Cigna did enter the Raleigh market for this current open enrollment, just a single rating area. So no one said that this market isn't viable, that there are sort of regulatory barriers that keep people from doing business. The rate increases that proposed were generally approved. It does appear to be mainly just a process of the actuaries catching up with the utilization. The points that Mike made about not knowing what the population was at first, and then the next year having to put in your rates before you really had good data, and by the third year, your reinsurance, your risk corridor payments were frozen by Marco Rubio, and then the fourth year, your reinsurance has phased out. So every year there's something else to catch up with, and so the points you already know. There's reason to believe it's found equilibrium, but there's also reason to be concerned that it hasn't. So I heard both stories, but I think the idea is that prior to the Trump election, people at least were carriers were continuing to watch this market carefully and remain sort of flexible in terms of reentry or new entry. And meanwhile, what had developed with the network, the private provider networks, was really, I think, most encouraging.
Okay, thank you very much. Mike.
So I suppose the best sort of single line about Texas that really plays off of Mark's comment is, and then it all fell apart. Texas is certainly an oppositional state. It didn't expand its Medicaid program. It uses a federally facilitated exchange. It enacted legislation requiring additional training for navigators before they could go into the field. And indeed, there are only a handful of formal navigators throughout the state. But I wanted to make one point before going into the collapse. And that is that the nature of those individual markets truly are sometimes very unique. One of the features with Texas is we have a number of border counties. And there the challenge is so let's see, I'm an insurer and I'm selling a bronze or maybe a silver product with a rather large deductible and then access to U.S. providers. And the majority Hispanic population in McAllen, for example, many can cross the border where there is a vibrant healthcare market, where they get a favorable exchange rate, and where prices are lower. And it's really difficult with that sort of opportunity for alternative sources of care to make an exchange product of the sort that we've talked about today really work. And I just want to throw that as an example of the sometimes very different markets that insurers are trying to function in. Then to talk about sort of the nature of the collapse in Texas. Alice keeps saying to me, "You're too negative. You're too negative." I was very enthusiastic about what was happening in Texas over the first 2 years. In the first year, as I indicated more globally, there was reluctance on the part of insurers to enter into the market. Blue Cross Blue Shield is the dominant carrier, present in all 254 counties. But after that first year, we saw substantial entry into markets. We saw expansion by those who were already there. We saw carriers lower their prices relative to the Blue Cross Blue Shield prices, and to appear to be competing pretty significantly, at least in some markets. Certainly, for example, in Houston and Austin, where we saw 8 and 9 carriers competing by the second and third year. But then the data became available, and when the data became available, as Mark indicated, big indications that there were losses, and it was those losses together with the perceived inadequacy of the risk adjustment mechanisms that led to withdrawals. So Houston, depending on how you count, third or fourth largest city in the country, had 8 insurers. They now have 3, Blue Cross Blue Shield and 2 Medicaid managed care plans. The other thing that went on is the shift from a variety of PPO offerings. Blue Cross Blue Shield offered PPOs in all of its markets, along with HMOs. Very quickly, it decided to withdraw from the PPO offerings, as did all of the other carriers. I mean, you cannot buy a PPO product on the exchanges in Texas. HMOs are the only ones there. There is certainly a view of significant adverse selection, and that it was the sicker folks who enrolled, and as a consequence, that undermined the premiums that the carriers had set with a high degree of uncertainty. And I would say, given the Michigan experience, where there's not a sense of a death spiral, there is a sense of a death spiral in Texas. I mean, had the election not occurred and the additional complications layered on top, there was, from my sort of back of the envelope calculations, sort of 50-50 sense among the people we talked to that Blue Cross Blue Shield would still be in the market next year. And Blue Cross raised its premiums rather substantially, at 40 to 50+%. In the first year, they appear not to have known what the utilization experience was. They announced that they had lost $440,000. They responded by moving from PPOs to HMOs, which is sort of a classic response that an insurer would make to deal with those kinds of cost problems. And they lost $770,000 in the individual market. So clearly there's concern, and they have responded with rather large premium increases. And as we've said, it's an open question whether or not those are going to be adequate to deal with the utilization experience they've seen. Now, having said that, the Medicaid managed care plans truly are a surprise, and I think a surprise even amongst themselves. As one of them said, we have succeeded beyond our wildest dreams in terms of the sorts of enrollment that they were able to garner. And they said, we basically didn't know how to price particularly. We followed Blue Cross, may have been a mistake, but their premiums have remained low. They actually rose up in the middle years and have come back down. Molina, as others have indicated, have lowered their prices in every year, at least in some of the markets in Texas. So there are bright spots, and there are those carriers potentially waiting in the wings to re-enter. But Texas is a market that I had great hopes for early on, because I saw lots of entry and I saw price competition and all the sorts of things that an economist would say, this is all moving the way you would hope it to move. And I guess better data quashed that. So what can I say, Alice? That's the best I can do.
Okay, well, very good. Well, even though it's not the case that it works, it seems to be, the system seems to be working in all of these situations. It does seem that, from what you have been saying, that the ACA model seems to work best in urban areas with non-concentrated provider communities. Now, I wondered, and not that it works in all urban areas with non-concentrated provider communities, but I wonder what can be done to make this model work better in the other communities. It's the rural communities or maybe the smaller city communities that might have more concentrated providers, relatively small number of hospitals, or increasingly, since the industry seems to be consolidating anyway, a lot of our cities, even pretty sizable cities, are going to have a fair amount of concentration. I wonder, I mean, is it something that could be done within the ACA itself, or should we be doing something about really building up our provider infrastructure with a separate set of policies? So what do you think? Anybody?
Well, I actually think it was very clear. You know, I think frankly, all of the issues that we've experienced in, I think, all of our states were fixable issues. Now, that is not what's happening right now. And in fact, as I say, there's a lot of chaos in the market. But this was very clear on what we could have done if we had the political will to do it, and that was the public option. I mean, you cannot overcome, and I can't remember which of you said, maybe it was you, Micah, said, you know, when you have limited number of providers in a community, the health plans don't have market leverage to negotiate lower rates, right?
Yeah.
You need to give them market leverage. So look at what's happened with Medicare Advantage, right? Medicare Advantage has worked very well in many of those communities, and it's because they have the leverage of the Medicare rates, right? So clearly, I think that would have been a way to fix it. I think we're not going anywhere near that at this point.
Yeah. Mark, did you have this?
Same thing. I mean, we planned all this, much earlier in the year, and did most of the interviews in the late summer and early fall. So prior to the election, and at that time, we thought that there would be discussion of the public option. So we actually asked people, and what we heard, and in North Carolina, so the eastern part of the state, which is thinly populated and where there's the least sort of provider competition, more often than I expected in a fairly conservative state, and not just from the liberal advocates, is, well, I suppose there's nothing left other than the public option, and who knows exactly what that would mean? Does it mean you just buy into the state health plan, for the state employees, or some much left up in the air? But there was sort of more openness to thinking about some version of a public option than I expected to hear. Now, we didn't pursue that in great depth, but suffice it to say that doesn't even just merit mention in the final report, because it seems that's so far off the relevant policy field. So that's one answer, is that if this model of managed competition, which is I really think what we're talking about, isn't viable, then that's the logical alternative.
I don't know. Let me swing to the other side, maybe, in your perception of my political preferences. Public option is giving up on this system and blowing it up, right? If we allow one of the quote-unquote competitors in the marketplace to have a completely different, essentially set of rules, and to leverage the, combined purchasing power of the state and all the mechanisms of the state, it's not a competitor at all. And it's not setting up a fair system of competition. And it doesn't address your question, right? You look around the world, they've got single payer systems. You couldn't find a, more, market leverage. Yet they've seen substantial trends, upward trends in their healthcare premiums and, utilization and so on and so forth. The issue is still competition, right? Not of not of plans, but of providers. So this is a really important issue, whether or not we move to a single payer system or, do the very interesting ideas from the folks on the right wing of essentially blowing up employer-sponsored health insurance and having effectively exchanges for all. We still need to think about, what do you do in non-competitive marketplaces? You could actually be serious about antitrust in urban areas, but you can't, really, antitrust doesn't work that well when there's one hospital, right? I don't know if you can, put a tape down the middle of it and be like, you guys are over here. But it's really important. And, telehealth may be one way to get some traction on that issue, and there are others. But this is these are like the real issues, not the imaginary ideological policy issues, but like the real issues that are going to matter if we want to be successful with any system that we choose.
Well, let me pick up on that because I agree with you. If the issue is the lack of competition amongst providers, one of the things we've seen is over the last couple of decades is really the willingness to allow providers to consolidate. So let's revisit the antitrust issues. Let's revisit some of those consolidations and see to what extent we can sort of unscramble the egg. And in some markets, we may be able to do that. In rural areas, probably not. But there are middle-sized urban areas that have consolidated into single networks that presumably could be at least revisited. Because the issue is competition. It's not the other stuff.
So let me say one other word since I spent 25 years of my career at a health plan, doing all of this negotiation, et cetera. And the other way to think about this problem is back to actually a point that you raised about the specificity of the rating areas, right? So when I was at Blue Cross and Blue Shield and we looked at the market as a statewide market rather than an individual regional market, the rural areas were not as big a problem because we were essentially letting them be cross-subsidized by the other regions, right? They're a small population. They have a relatively small impact on a health plan's profit margin in total. And so we could afford to pay higher rates to the providers and still keep premiums lower if we looked at it from a statewide basis. The way the ACA is set up now, each market stands on its own. And so another way to look at this problem is to think about rating area structure and think about statewide plans where there can actually be some cross-subsidization.
Absolutely.
And you don't want to get bogged down on this one, but when I was in the discussions when we came up with our 16 rating areas, and we talked about, do we have 100 counties? Do we have, 4? Do we have whatever? And a lot of the balance was explicitly about this cross-subsidization, where, and the counterpoint is that, well, if you too broad a rating area and too much cross-subsidization, then you don't really reward the plans that do negotiate the discounts with the more centralized health systems. And so there are trade-offs, but that would be the other approach. Yeah.
Yeah, I mentioned that in the beginning of my discussion of Florida, that 67 rating areas may just be too many. And in fact, one that I chose is the poorest county in Florida, Gadsden, but it borders Tallahassee and Leon County, which is where the legislature is. It's where Capital Health Plan has great networks of providers. And in fact, people in Gadsden that need services can drive 25 miles to all the best hospitals and providers in the state. But the network that's there offers them one hospital over in that side of their county, and the consideration here of merging those counties in some way, the fact that that's not on the it's not being considered just yet, it surprises me.
Well, another thing, it does seem as if one major theme that comes out of your discussions is that when you do have something like the ACA, which is a very complex market-based initiative, that it's going to take a while for all the different actors, the consumers, the providers, the insurers, the regulators, everybody to sort of adapt to one another and sort of understand things. But it also seems that the consumers in particular still need quite a bit of help in this system. And I know Patty talked a bit about what sounded like a very good program coming out of University of South Florida, but I was wondering if you have other suggestions about how, are there ways in which we can actually sort of help consumers not only understand how to get into the system, but how to use the services in a way that that is more efficient, more effective than they have so far. So are there any particularly good practices you think that ought to be spread, or do we need a lot more person power in doing this sort of work? How can we improve consumers in dealing with this complex system?
Well, one approach is the agents and brokers have largely been excluded from all of this. And when they were participating, admittedly, most of the focus is in the small group market, not in the individual market. But these are folks that have a depth of knowledge on how insurance works and how it could work for you. And it seems to me that one of the things that could be considered in that much broader milieu of what are you going to change and how are you going to do it, is to reconsider the roles of brokers and agents and give them some skin in the game to be willing to help people make informed decisions in the individual and indeed the small group market on the health side.
Yeah, and Mike and I are just going to spend the whole panel agreeing with each other. So I
why we sit on opposite sides.
I spent all this time lobbying covered California, and I'm like, so you're setting up an insurance sales marketplace. Maybe work with insurance salespeople? Crazy idea. And we actually did compensate them a little bit in the early going. The compensation has sort of gone down. It's the brokers and agents in California are almost doing this as a charity at this point. But they're doing a tremendous job, and they're actually still providing a lot of the enrollment in the system. So that's a piece of it.
Okay.
Just chiming in on the broker-agent situation, it came up a lot in discussions in my interviews in North Carolina, like in other states. When United decided to pull out, they stopped paying commissions or took them down to 1% or whatever, particularly during special enrollment, because they cleared out open enrollment, and then they said, no more commissions. Once they did that, then Blue Cross did the same. And when Blue Cross zeroes out commissions, the brokers are really worked up. And they only did it during special enrollment, but I think it's because we can't be the only ones in the market paying commissions during a period when we think we're getting adversely selected. They reinstated commissions during open enrollment, but at a lower level. And so brokers who had been engaged, which were a minority, were saying we're pulling out. So that is a problem, and I think it really does pose concerns for the ongoing. Now, if it becomes more profitable and there's more competition, there's no reason that broker commissions couldn't go back up. Meanwhile, the role of the navigators has been critical, and I think one of the things that I learned from this is that the navigators weren't important just to get previously uninsured people educated about insurance and deductibles and things like that, but year by year, because of this sort of shift in pricing that, Micah, you referred to, where a plan one year is low price and then another plan drops lower and that price becomes much, much higher because it's relative to the subsidy, which the subsidy amount shifts, and people in the room know that dynamic. Suddenly, people are having to take another look, and when they change, they're changing providers, and that gets pretty confusing. So you could call that turmoil, but you could call it sort of active purchasing, price-driven. But whatever it is, it requires more than just sort of punching it up and seeing who's got the best price this year.
I want to add
Marianne,
one more thought to the dialogue, because it comes back to something Mike said earlier about the states that expanded Medicaid and the states that did not. So in the states that expanded Medicaid, there actually is quite a robust network of organizations and individuals who are helping people get enrolled in Medicaid, and they're actually serving the same function for the exchanges, right? So I think this is another case where you can see when you expand Medicaid, it has spillover effects into the individual market.
Okay, good. Okay, before I turn it over to everybody, I'm going to just ask one question, and or one combination question, and I want you to answer briefly. The lightning round question. So, I have heard some discussion about the ACA, some interest in possibly changing the ACA at the national level. So I was wondering if you could offer your suggestions or your thoughts on what element of the ACA do you think is absolutely necessary to sustain, or what element should be strengthened, or what element could be jettisoned without too much trouble. You don't have to answer all three of these, anyone, but if anybody has any thoughts, any recommendations based on your research, based on your own state's research. Marianne.
Well, so on the jettison side, I do think the employer mandate could be jettisoned. I think it's not served much of a function. It was sort of a throw-in anyway at the end, and it's very much of an irritant to the employers. They're maintaining coverage. We have not seen a drop in coverage from the employers, despite the prediction. So I think that could be jettisoned. On the maintain side, again, the idea, you have to have some incentives for people to enroll. You have to have a mix. We can spend quite a bit of time on talking about why high-risk pools will not work as proposed, why health savings accounts are not the answer. You've got to get healthy and sick people in the market. That is how health insurance works. And so, if it's not going to be the individual mandate that people hate, I'm very concerned about the continuous coverage requirement, or frankly, the idea that we can do it like Medicare Part B. We need to strengthen, I think, the individual mandate. Clamp down on the special enrollment periods and some other things that have really caused problems.
Well grounded in Michigan's experience with Blue Cross Blue Shield.
Indeed.
Okay, very good.
So
Patty.
I would guess, and I'm going to pull these from the main concerns that the stakeholders I talked to conveyed. We've got to find ways to keep enrollees from opting in and out of coverage. Yeah. There seems to be a sense, especially among the regulators, that people are signing up during open enrollment. They're using the first few months to get things taken care of, and then they stop paying. And trying to convince individuals that you're still bearing risk if you're not insured, and you should consider paying for the whole year. So some ways to incentivize people to stay in. And as far as something, I don't have anything I'd really want to jettison, but I think the risk adjustment mechanism needs to be reconsidered somehow, so that we can encourage those providers that are the carriers that are getting adversely selected against. Somehow there's some time period in which they can recover and stay in the system, rather than feel like they didn't get duly compensated for the risk that they bore in a given year and decide to leave the market altogether.
Okay.
Before somebody takes my one idea, I'd love to jump in on that, which is
That would be me, I guess.
I do think that particularly there are the 3 R's, and we could spend all day talking about what each one means, but just to emphasize, 2 of the 3 R's were transitional, risk corridors and reinsurance. And it struck me through this process that the 3-year transition was too short. Of course, the risk corridors were never adequately funded. And then even with reinsurance, I think the market needs another year or two to kind of really get caught up and get comfortable with the level of risk and the pricing for the reasons that we've talked about. You can look to Medicare Part D and Medicare Advantage, where the 3 R's are actually permanent. And that's where the ideas came from. There, too, you had a very similar managed competition type of idea where it was not hostily opposed and it was embraced, and all elements worked together to try to make it work. But importantly, the risk mitigation things, and I don't know that they need to be permanent, but only 3 years in a hostile oppositional environment and only partly supported versus the other experience with Medicare Part D.
Okay, good.
Well, I would put two things on the list to worry about and keep. One is the exchanges themselves. They don't have to be run by states or the federal government, but this idea of a single place where you can go and see what all of your options are is worth preserving, and it can be preserved privately. I mean, ehealthinsurance.com prior to the ACA was able to do that sort of thing. And there's no reason that private entities couldn't do it, as well, maybe better than state and federal entities. But the idea is to insist that everybody who is offering coverage, be on the exchange and be explicitly described as what they're doing. And secondly, is improving somehow the issue of dealing with adverse selection. I mean, as both Patty and Mark have talked about. That's a really big issue, and if you're not going to allow people to charge insurers to charge a higher premium when you're for sicker folks and lower for healthy folks, then you've got to find some mechanism to account for that difference in expected utilization. Maybe it's the 3 R's being improved, and it very well maybe. Maybe it's looking creatively at things like high risk pools, but in any event, that issue has to be dealt with. if any of this is to succeed.
Yeah, I guess very quickly, guarantee issue and community rating, are what I hope gets preserved. So as long as if we do those, then you can move the, pieces around a little bit. I think what can be jettisoned is a lot of the complexity. Like the second lowest silver plan with the percentages and the cost-sharing subsidies and everything. And I talked to so many reporters, and they'd be like, premiums are going up. And I'm like, no, they're not. It's actually way more complicated than that. They're like, well, but we can't possibly explain that to our audience, right? So if you have a law that you can't possibly explain, that might not be a feature. Certainly looking at how we can simplify this and maybe simplify the broader healthcare system more generally.
Excellent. Well, thank you very much. And now, anybody, brief. I'll get to you in a moment, Dick. Yes, ma'am.
Yes, very quick.
We have a microphone for you.
Hi, my name is Deneen Grooms from the American Speech Language Hearing Association. Earlier, it was mentioned that interstate sale wasn't really a viable option, but could you explain a little bit more why it's not a viable option?
Well, it's a testable hypothesis that it isn't, and I early on thought that indeed there's a lot of potential there. The problem is that if I'm an insurer and I want to be successful, I've got to negotiate prices with providers, and those providers exist in local communities. And so if I'm headquartered in Tennessee and I'm offering insurance in Texas, I've still got to go to Midland and negotiate a contract, and that's time-consuming, and I don't know what kind of market. I just don't think you see much of that happening, at least very quickly.
Yeah, the sale of insurance across state lines either does nothing or does something we don't want it to do, right? If it is just like people being able to sell in other markets, they kind of can already do that. They'd have to abide by the state regulations, and they have to figure these things out. However, if sale of insurance across state lines means there's a state that allows you to sell junk insurance, and so you can now everywhere in the United States sell a plan that has a yearly maximum, well, that'll get you to a lower premium, but in a disastrous way. So it's either nothing or it's a big problem.
Okay, good. Next question, right over there, this lady. Yes.
Thank you very much. I'd like to ask a question about the impact of dominant employers in states or regions. If you were in Wisconsin, it would be potentially Kimberly-Clark. Ford potentially in Michigan. Mm-hmm. And they had employer plans, and R.J. Reynolds and Winston-Salem, if they still have their headquarters. They still offer Yahoo or Facebook, they still offer their employees health plans. 20 years ago, they would have offered them kind of one health plan, whether you were an engineer or a janitor. So two questions. One, to what degree did having a dominant employer impact these various districts and states? I mean, even Houston and Dallas have some dominant employers. And second of all, if there were a repeal of the ACA, how would that impact these employer plans?
I can comment on the dominant employer because I think it goes to what I was trying to communicate earlier about the history of the states and how important that is and what got set up under the Affordable Care Act. So, for example, in Michigan, which was for many years dominated by the auto companies and the UAW in terms of the way health benefits were designed, because they concentrated their insurance market into Blue Cross and Blue Shield of Michigan, it gave Blue Cross and Blue Shield of Michigan tremendous leverage in negotiating with the providers in the state. That's what set the ground level, and that's what kept premiums relatively competitive and relatively low in Michigan. So they're less important now because, for a variety of reasons, but I think that they set up the foundation of what we're dealing with in the states and became very important. I don't think they are directly affected very much by the repeal. I mean, they may be by the preventive benefits or whatever. They are 100% offering benefit coverage. Most of them are moving to high deductible health plans that is independent. I mean, people are confused about this. It's independent of the ACA. I think they're still on that journey.
Yeah, I mean, just one more question quickly. Actually, the ACA has been fantastic for employers. So, particularly in states that did the Medicaid expansion. So in California, as an example, 2/3 of the adults who are enrolled in Medicaid are actively engaged in the labor force. They're employed full-time, part-time. They're people that weren't necessarily on the employer-sponsored health plan. Well, what happens when you have Medicaid? You're more productive. Your health status is better. So there are lots of positive impacts for the employers and for the economy of having these plans in place, and for the people whose may not be covered by employer-sponsored insurance. They have family members that are covered by an individual. So it's not costless for employers if we get rid of the ACA.
Thank you. Dick?
I'd like to make two quick comments, having lived with these wonderful characters for a long time. They did a great job, I think. I was pleased, Patty, that you mentioned Florida is number 2 in enrollment, despite the politics. Vermont is the only state that has a higher enrollment. I was pleased because we both were there that the navigator, Jody Ray, you mentioned her, she's quite special. The second point that I would just like to make as a quick point is that in regard to rural areas and low density areas, Alice will remember, Mike will remember, we did a 5-state study for the Assistant Secretary and HHS, ASPE, including Alaska. And Alaska now, and we have a field researcher there, and we know the field people and the state people, and he was a state official like Marianne. They are trying to do something new in Alaska, and that's one of the kinds of things that didn't come out as much here because Alaska... In fact, when they asked us to cover Alaska, we thought, my goodness, it's so different. But all states are different. The final point I want to make is sort of a philosophical point. And Micah, you mentioned David Brooks's column, where he talked about Kenneth Arrow, saying people should choose. They should decide what they want. What's really here, the competition that's really here, and then you mentioned Alan Enthoven, is competition among the plans. It's more than just insurers, more than just carriers. There are a lot of ways in which entities are playing a new role. In his book, which I like, Zeke Emanuel at the end has a section about how fundamentally, eventually, insurer roles are going to change. It goes way beyond anything we're seeing here. But they are changing. When we start talking about institutional change on the part of insurers it's not just a government stuff. It's not just government stuff. It involves both sectors, public and private. I thought you guys did a great job, by the way.
Thank you very much. Okay, we have, I'm sorry, just a couple of minutes. So please, I'm going to ask you to each state your question very briefly, and then I'll let them talk. Okay, yes, sir. Oh, he'll be over in just a sec.
Larry Checo. I'm just wondering, would we all be sitting here had the ACA been universally embraced by all the states? And what would that have done for competition, premiums, and risk pools? Thank you.
Okay. So, yes, sir. Over the other side. This gentleman over here. Okay. It's coming. It's coming.
Lou Gagliano. To the extent that the premise is wrong, that the current pricing properly adjusts for the risk pool, what should federal policymakers take away from the higher utilization rate of impact that it had early on in terms of structuring a replacement bill? Thank you.
And this, okay.
Is that just two? Okay.
And right over here, and this will be the
We're gonna each
third.
take
I'm
one
sorry.
of these.
Okay. 2 more.
Hi, Fiona Gregg. Just quickly, what do we know about the impact on out-of-pocket expenses for families? obviously utilization might have gone up, but they're now paying a premium and maybe deductibles. And so just what is the state of play from the consumer budget standpoint?
Very good question. And one last one, right behind there.
Write these down. I'm just wondering when the discussion, or essentially the broader focus, moves to effectively lowering the cost of service and essentially making the talk of premiums and subsidies, which are essentially cost shifts, irrelevant.
Yeah, no, that's very good. Okay. Some of these will have to be answered, I think, in the next session maybe, or be addressed. But does anybody have any quick comments on any one of these questions? They're all great questions.
Well, I mean, just quickly, like, we're talking about the actual cost of care. When you're talking about competition among providers, right? If you're just talking about health insurance and cost sharing and so on, you're just moving the deck chairs around in the Titanic if you're not actually dealing with the big issue, which is there competition in your marketplace? So that's what we're focused on. That's what any policy approach is going to have to focus on. Just quickly to the question about out-of-pocket costs, there's an irony here, which is that the one thing that consumers have said they absolutely do not want more of in whatever the replacement plan is higher out-of-pocket costs. But the only move that the Republicans have proposed is higher out-of-pocket costs. So there's a disconnect that's going to have both policy and political consequences.
Yeah, so, and on that point, the cost-sharing subsidies were extremely important. So many people who are at very low income scales have really benefited tremendously, which of course are under attack in the courts at the moment. So we'll see what the Republicans do with that. That is fundamental to the health plans that those cost-sharing subsidies stay in effect. They really, and we really have underreported the financial help people have gotten through the tax credits and those cost-sharing subsidies. They are really important. A comment on if everybody had embraced the plan, I think we would have such a different conversation today, because there's so many elements of this plan that are fixable, and we're really not focused on what is fixable. These issues about people coming into coverage for short periods of time, in our case, people getting Sovaldi, and then they drop their coverage, and that has had significant impacts on the affordability for everybody, right? It's raised the premiums for everyone. So there are a lot of things that are fixable. If we had embraced it, as a country, we would be in a very different conversation now.
I want to extend from that too and say if we had embraced it, the Affordable Care Act addressed financing issues, and we're talking about costs still being kind of high. What needs to be considered still is what we're doing in the healthcare community, the pushing for more efficient healthcare services. Affordable Care Act did not address incentives to providers as far as it could have to find cost-effective treatments, to address places where there might be more efficiency in the healthcare system. There are some, but I think we could go further in that direction. So even if we were sitting here saying everyone got insurance, we'd still be wondering, everyone's got insurance, they're paying for it, but the prices are high. What are we going to do next? Well, now we got to figure out why everybody's spending all this money on healthcare.
Well, maybe we'll bid for pharmaceuticals.
I don't think we can.
What? That work? Okay.
No, I think we have to.
Great. Right.
We have to cut it off. And but I really appreciate. I appreciate the extra 8 minutes we've had. So thank you very much.